Thank you so much, Kevin, and it was fine that you went over time. It was so important to hear your message, to hear about carers, to hear what carers have to go through. And I really liked that phrase that you said, that equity is not about everyone getting the same, it's about everyone getting what they need to get the same outcome. And that really hit me, and I think that's what everyone in this room wants too. So we heard how valuable it is to hear from the carer perspective, but what to do about it. We're going to learn more now about how feedback and experiences of people with cancer can shape clinical outcomes. We're going to hear from Professor Tracey O'Brien AM. She's the New South Wales Chief Cancer Officer and CEO of the Cancer Institute of New South Wales. She has more than 25 years' experience as a health executive, an oncologist, a clinician-researcher. And she's going to talk about innovation to address rare cancers and how patient-reported outcome measures and experience measures, known in the trade as PROMs and PREMs, can change clinical practice and improve outcomes. It's basically about taking note of what patients' experiences are like, asking them, and then putting their thoughts and experiences to change the way medicine is delivered. Please welcome Professor Tracey O'Brien.
Thank you very much, Sophie. Rare Cancers is lucky to have you as their resident MC. You truly are the master of blending compassion and storytelling and that much-needed critical discourse. And Christine, congratulations to you and the entire Rare Cancers team for such an important and powerful advocacy and the invitation to speak. And to Caitlin, or Kevin, bloody Kevin, as I'm going to call him now, who wouldn't want to be me following that presentation? I mean, that was so powerful, one of the most powerful presentations I've heard. I was secretly hoping it was being piped directly into the House of Reps and Senate to get the message across. So thank you for bringing that really important message of carers to the conversation. The Can Forum 25 theme, now it's personal access and equity for all, does truly resonate with everybody in this room. And today I wanted to share how we're personalising cancer care at the bedside in New South Wales through our statewide patient-reported measures program. By elevating the voices and the unique needs of individuals with cancer, we can make care more responsive and ensure that it delivers what matters most to people. In many ways, personalised care starts with voice, not data. And when every voice is heard, care becomes more human, more responsive, and ultimately more effective. Access and equity for all is then the natural extension of that vision. It's not just a theme for today or a principle on a cancer plan, but a responsibility that demands action. I, too, would like to acknowledge that we're meeting on the unceded lands of the Ngunnawal and Ngambri people, and I pay my sincere respect to elders past, present, and honour strength, resilience and the enduring cultures of Aboriginal people, and I extend that to Aboriginal colleagues in the room here. I'd also like to acknowledge that for Aboriginal people, cancer outcomes remain starkly unequal, and changing that reality is one of our greatest responsibilities, and we must face that together. I would also like to acknowledge those that bravely share their lived experience of cancer and work in partnership directly with the Cancer Institute in New South Wales. Their courage ensures that our work is always grounded in what matters most and reminds us that behind every statistic or piece of data is a person, is a family, and as a community, as Kevin so rightly said. For those of you less familiar or from outside of New South Wales, the Cancer Institute of New South Wales is a legislated health pillar. It's board-governed organisation dedicated solely to the cancer control in New South Wales. Cancer's complexity lies really at its diversity, with hundreds of diverse pathologies and different diseases, spanning every specialised care across every part of the health system and every dimension of a person's life. For patients, for families and for communities, the impact is profound, often for months, years, even decades. Meeting that challenge really does require a coordinated response. And that response needs to be evidence-driven. It does need to be data-enabled, it needs to be equitable, and it needs to be constantly evolving. We need innovation that doesn't just keep up, it pushes forward. Now, we're guided, our work in New South Wales is guided by what is the 5th cancer plan of New South Wales, and it's driven by 3 core principles: equity, person-centredness and collaboration. Now, even as the peak government agency for cancer in New South Wales, we cannot achieve this alone. More than 80 partner organisations across New South Wales work together with the Institute often acting as the linchpin in collaboration and system reform to help deliver impact across health, across research and across community. The goals of the New South Wales plan align very well with the Australian Cancer Plan, and we are absolutely 100% working towards national efforts for progress. Now, New South Wales has terrific cancer data, and data is one of the greatest assets of the Institute. But I can't stress enough that data is only powerful when it's used purposefully. In many ways, it's not about collecting more data. We do have a lot of data already. It's not about waiting to design the perfect data set or even over-engineering a solution. It's about using the right data at the right time for the right purpose. Whether that's at the bedside in real time, and you need real-time data for that, or to benchmark and improve individual cancer units, or to plan from a statewide point of view, or it's about shaping tomorrow's solutions through making all of that data available for research. It's purposeful use of data that drives real change. And our philosophy is collect once, make it available, and use it as many times as possible. This is a slide just to show schematically our data architecture in New South Wales. By centralising the data into an agency and capitalising on data linkage to other health system data that's already available, we avoid duplication. We suck it in as automatically as possible to avoid time at the bedside for clinicians to enter data and duplication of costs. And importantly, we can capture the continuum from prevention and screening through treatment, clinical trials, survivorship and palliation. And then by linking that data, cancer data, to other non-cancer data and federal and state data assets which contain rich social, cultural, economic determinants, we can piece together a more comprehensive landscape that better equips us to tackle access and outcome inequities for the vast and quite diverse population of New South Wales. Now, in New South Wales, of course, we are the most populous state, and we represent 1/3 of all Australian people, and we're proudly home to 1/3 of all Aboriginal and Torres Strait Islander people, and it is the most culturally and linguistically diverse community. In New South Wales, every 10 minutes, a person is diagnosed with cancer. And despite decades of progress and some of the best survival rates in the world, for some, but not all cancers, as we all know in this room too well, sadly, every 30 minutes in New South Wales, somebody still dies as a result of their cancer. So our challenge is far from over. For rare and less common cancers, in New South Wales, rare and less common cancers make up 1/4 of all diagnoses and make up 1/3 of all cancer deaths in New South Wales. Now that equates to someone being diagnosed with a rare or less common cancer in New South Wales every 40 minutes, and someone sadly dying from a rare or less common cancer every 90 minutes in New South Wales alone. So the impact of rare cancer is disproportionately heavy on patients, on families, and on the system itself. For people in rural or remote New South Wales, the picture is starker. They are more likely to be diagnosed and more likely to die from a rare or less common cancer. And disadvantage also compounds risks. Those in the lowest socioeconomic group are 1.5 times more likely to die of their rare or less common cancer than those in the higher socioeconomic group. But these factors don't stand in isolation, particularly when we're talking about provision of outcomes for populations, not individuals. It's not quite as straightforward as saying it's simply about postcode determining your outcome. It is a little bit like peeling an onion. Geography and economic disadvantage intersect, and it also intersects with other social determinants like level of education and even modifiable risk factors like obesity. The key takeaway is that inequities in rare and less common cancers mirror those seen in common cancers. And truly solving for cancer inequities will require a multifaceted, intersectional and a cross-sector approach. Health cannot do it just alone. So, how do we move towards more personalised care? Well, patient-reported outcome measures, or PROMs, are one way that we're doing it in New South Wales. Globally, they've been used for many decades, often as research tools in academic inquiry, to more recent years where they've become fundamental in clinical trials, helping to shape drug acceptability and approvals. Much of those uses are collected from individuals at a point in time, and then they're reported as an aggregate patient representative data, often months, sometimes years down the track, dictated by the purpose for which they were collected. And these are all important uses. In New South Wales, we've chosen a different path. We're concentrated on using patient-reported outcome measures to act in real time at the bedside to personalise care. Now, our philosophy in patient-reported measures, we think, lets us see the person behind the cancer. Questions get asked: what matters to you? What worries you? What support do you need today? They do have the power to connect that voice directly to action. As I often like to say, when care listens and responds, care improves. Now, our principles when we began were simple. Keep it at the point of care. Above all, if you asked, act on it. If it doesn't lead to action, it's just another survey. So we settled on using 3 simple validated tools. We didn't reinvent the wheel, and these were applicable to all cancers: a distress thermometer and a problem list, and the ESAS, or Edmonton Symptom Assessment Scale, and then the What Matters to Adults cultural and wellbeing tool for Aboriginal people, which was designed by Professor Gail Garvey and informed by the voices of hundreds and hundreds of First Nation people. We resisted clinicians and many advocacy groups who wanted longer disease-specific tools. We were cognizant that we had to start somewhere. We had to change culture, and we had to build something that could be implemented flexibly and equitably at scale, and that was a big enough mountain to climb. Now, our journey has been quite a slow burn, actually, from early clinician-driven local teams at Liverpool and Illawarra hospitals, and I'll just acknowledge Afa Gergis and Jeff Delaney and Anthony Arnold as leaders of that work in New South Wales, to a statewide rollout which the Institute picked up and took control of. And that was ground to a halt because we tried to do it in the middle of the pandemic. And now we're really starting to gain some momentum today. Patient-reported outcome measures, as of today, are embedded in every public cancer service in New South Wales, and more than 31,000 voices are helping to shape personalised care. Now, I don't want to oversell or have you leave thinking we've got it all sorted in New South Wales. I really see that we're just getting going. But the foundations are strong, the clinical engagement is high and it's building, and there's accountability and there's transparency, and there's even a little bit of healthy competition across the 50 or so cancer units continuing to drive performance. The patient-reported measures have been embedded into our statewide reporting better outcome quality improvement program, and I share personally results with chief executives of all of the local health districts, the cancer directors and the frontline clinical staff in annual performance meetings. And this year we hope to release a snapshot of our first statewide public report on both patient-reported outcomes and experience measures, really bringing full transparency to how we are attempting to ensure and improve cancer care for individuals. Now, this has all been done on the smell of an oily rag with very minimal investment. Just a team of 3 staff, that's all. We've learned many valuable lessons along the way, but the number one take-home implementation would be build it into local workflow, not on top of it. I can't stress that enough. This is how, This is how it works. On the right-hand side is the business as usual wheel. Patients complete a short electronic survey at their outpatient appointment, or they get sent it a day or 2 before they attend the appointment. It takes no longer than 5 minutes to complete. If defined thresholds are breached, an alert is triggered and it goes straight into a patient's own medical record so that the issue can be addressed on the spot at the clinic visit or a referral made if required. Every person, every time they complete the quick check-in, is offered information tailored to what concerns they have at that point in time. We can also drive continuous improvement and innovation through the same simple system that's on the left-hand side. The left-hand side, 5 degrees, and I have to sit there with my left and right to work out which one's which. The left-hand side of the wheel, and that enables sort of testing and iteration in a defined setting so that we can work out what works and then scale it. So, for example, we're currently testing a palliative care tool with several large private faith-based palliative care services, and we'll soon embark on a paediatric and adolescent tool as well. Now, the patient-reported outcome measures are available in 11 languages, and there is a dedicated Aboriginal tool, as I mentioned, that is supported actually by face-to-face Aboriginal cancer care coordinators that we've embedded within the local health districts. Around 30% of patients reach the distress thermometer, helping to target what concerns need immediate action. Now, in terms of the framework of implementing this, the framework is flexible. It allows local services to use the patient-reported outcome measures in the best way that serves their unique community and works in terms of the workflow at their site. So in regional New South Wales cancer centres, many of the centres choose to send their patient-reported measures tool to people a day or 2 before their scheduled appointment. So it can give early insight to staff so that they can organise what a person may need at their visit, whether it's community help with transport or childcare to actually physically get to the appointment, or making sure that scans and tests are all lined up so that it can be done on the same day to save what are often large commutes. Clinicians worried if we ask these questions, we won't have the services to respond. And this was often cited as a barrier to beginning. What we've learned is the exact opposite. Most people don't need new services. They want to be heard, they want their concerns validated, and they want the issues that matter most to them addressed in that moment. And anecdotally, most staff now report it actually makes better use of clinical time and services. Allied health staff, for example, can focus and support where it's truly needed instead of checking in with everybody. And because information is sent automatically on issues that patients nominate, conversations in clinics are sharper, more solutions-focused, and sometimes they're not needed at all because the questions have all been answered already. In fact, 60% of patients ask for more information after completing the tool, and they get it right there on the spot, and for most, that's actually all they need. We haven't reinvented the wheel with information. We've connected to sources of information through different cancer councils, rare cancers, so that you get the information that it's available. It's not about flooding people with detail, it's about timing, the right information at the right time. I like to think of it a bit like Instagram nudging you just when you're most likely to click, only here the nudge isn't for shoes you didn't know you needed to have. It's for care, the care information that matters to you most in that particular moment. So I share with you Lisa. She's shared her story with permission. She's 35, a single mum, living with her son, a young son, and has metastatic colorectal cancer. And through her patient-reported measures, she shared worries that she actually hadn't voiced with her care team at all about her financial stress and who would care for her son. So the team was able to respond and connect her to community-based services that helped her with childcare, with financial counselling, and with guardianship planning. For Lisa, this wasn't just about paperwork. It was peace of mind. It's what she needed to then focus on her treatment. And it only came about because she was asked, people listened, and responded. For others, cultural barriers particularly make a lot of topics taboo. This patient was incredibly thankful, was very worried just about being able to afford food and didn't know that we could provide this kind of help. That's what 5 minutes can do: build trust, restore dignity, create equity, the essence of personalised care. Now, the Aboriginal Wellbeing Co-Design tool, What Matters to Adults survey, embeds cultural, spiritual and community values. These tools are hopefully starting to make services safer, more responsible and particularly accountable by measuring what matters, although I acknowledge we have much more to go in this space. Elevating the patient's voice shifts care beyond treating symptoms and disease to supporting health and well-being. It uncovers needs that the system often miss and shows where services fall short and may need to focus. Some services have successfully used their information, their patient-reported measures, which we give straight back to them at a unit level as well, to build business cases for additional resources. Now, our early data tells us something that we knew. I'll skip over in the interest of time there, and that is that people with rare and less common cancers do show higher levels of distress compared to people with common cancers. Rare cancers are shown in the purple column and common cancers in the blue columns. And there is also higher symptom burden across the board, breaching thresholds for nearly every symptom in people with rare or less common cancers. And these signals are helping staff to act earlier and services to be more responsive. Now, lastly, I'll just mention patient-reported experience. We also have a system where we survey everybody in an oncology outpatient clinic, in every single outpatient public health clinic, as well as many of the private oncology clinics as well. This is done as a census-type study. It's done across 1 month of every year, and it's reported publicly as well. And pleasingly, most people are reporting high levels of good experience in terms of respect, dignity and good care. But there is a way to go, and there are gaps that still remain, and they are in navigation and financial stress. So I'll end where I began. I think personalised care does start with hearing what matters and then acting on it. At the Cancer Institute and right across all of the cancer centres in New South Wales, we do see patient-reported outcome and experience measures not as a nice-to-have or an add-on. We see them as fundamental drivers of personalised care, because when care listens and responds, care does improve. Thank you for your attention, and I'm happy to connect and share any of this information with anybody that is interested. Thanks very much.